Good morning. So good morning and welcome to Medicine Grand Rounds. And it's my pleasure each year to introduce our Clem Finch visiting professor and to say a few words about Clem. So intriguingly this year, I will say up front that I was actually Clem's last fellow in that he recruited me to this program as a clinical fellow, and he was my attending in June of the last year he was here, which was our clinical year at the University of Washington Medical Center. And then after he retired, he went to continue his science at Providence Hospital. And Mario Cazzola, who's going to be our Clem Finch visiting professor today, was actually his last research fellow. So we share that, and we share that in honoring Clem this morning. So Clem was head of the division of hematology for 31 years. He founded the division. He came directly from his postdoctoral fellowship to be division chair. It was a different era. And he grew an amazing division of hematologists here in Seattle. So Clem was known for a number of other things. He was quite a good athlete and always wore a bow tie. I note that two or three of the faculty members have kept that tradition in the Division of Hematology. And he also had very, very many huge accomplishments in the fields of hematology broadly, red cells, iron, kinetics, etc. So he defined iron kinetics and its physiology. He studied transferrin biology, and he actually predicted via his physiological studies the existence of mediators such as ferroportin, hepcidin, and erythroferrone that we take for granted today in terms of their physiology and purpose. He described red cell development and the physiology of anemia, in part using iron kinetic studies. He showed that hemochromatosis was due to the hyperabsorption of iron in the GI tract rather than another defect, and therefore could be treated with phlebotomy. He defined better ways to store blood and was very active just broadly in transfusion medicine. And he helped the World Health Organization understand nutritional anemia in the developing world and champion iron supplementation of food, which was a first for that organization. He actually made a lot of contributions to nutrition and to iron deficiency. So between 1959 and 1980s, he was a consultant on nutritional anemia for all projects of the WHO and traveled quite extensively. Those are some of the countries where he wrote and traveled to. And this in part led to some of his eclectic dress, because he would wear a Peruvian vest with a bow tie from somewhere else. And he was awarded the Bristol Myers Award for Distinguished Achievement in Nutrition in 1985. This is just one of the pictures that was part of that celebration, showing his work in Gambia. So my memories of Clem. I was the last of his clinical fellows. He was very tall, as shown there. Very smart, an extraordinarily creative scientist. He was an excellent observer of patients, which really drove his science, and a listener. Very eclectic in his research interests and also in his personal interests, whether it be his choice of clothes or his pets or whatever else that was around his artwork, and a creative problem solver. And one of the stories that's always told about Clem is how he locked himself out of his 12th floor office in the BB building, so he used his rock climbing equipment and climbed outside and got in the window. So with that, I'd like to introduce Mario Cazzola, who is our Clem Finch visiting professor this year. And so we keep Mario very busy. This is his first stint, but he'll be giving Heme Grand Rounds and a blood club presentation, speaking to fellows and speaking to beginning faculty. So multiple presentations over his next 2 days. And so Mario started actually at the University of Pavia for his, in Italy for his degrees in medicine and his residency in internal medicine and in hematology. And then came to Seattle and joined Clem from 83 to 85. And studied and it was part of some of Clem's work on iron. But he took that work in the study of clonality that was very common here to begin his own career at the University of Pavia, where he's risen through the ranks and still is, to study myeloproliferative diseases and myelodysplasia. And he's actually bridged translational medicine in the true sense of the word. He takes care of a large group of patients and has always kept a good database and repository that allows him to answer a lot of molecular questions about the pathogenesis of myeloproliferative diseases that he'll speak about today and myelodysplastic diseases that he'll speak about tomorrow. And he's been part of really every major development in both of these fields as a contributing scientist. He's been very active in both the European Hematology Association and in ASH, the American Society of Hematology, and currently serves as an associate editor at Blood. He was the medical director of the group that did the 2016 WHO criteria for MPNs and MDSs. And it's just a pleasure to have him talk about this interface of how we can use thinking about patients and molecular insights to understand the pathogenesis of MPNs and today and MDSs tomorrow. Thanks.
So thank you very much. It's a great honor to be here. I came here in 1993 and I couldn't imagine at that time that I would become a Clem Finch visiting professor. So I will start with my disclosure slide. I have essentially no disclosure. And I would like to move from a paper published by John Adamson in the New England Journal of Medicine in 1986. When I graduated MD, we didn't know that Polycythemia vera, essential thrombocythemia, and primary myelofibrosis were malignancies or clonal diseases. And the first evidence was provided by John in a study of 2 patients that were heterozygous for G6PD isoenzymes. And essentially, John showed that these 2 patients were heterozygous in skin fibroblasts and T lymphocytes, but clonal in erythrocytes, granulocytes, and platelets. And so this was the first evidence that a somatic mutation was responsible for clonal proliferation in Polycythemia vera. And Phil Fialkov showed essentially the same findings in patients with essential thrombocythemia and primary myelofibrosis. But it took several years, probably 30 years, to identify the somatic mutations responsible for clonal proliferation. And in 2005, JAK2 V617F was identified. Then MPL exon 10 mutation, and then JAK2 exon 12 mutations, CALR exon 9 indels, and more recently non-canonical mutations in MPL. And we contributed to the identification of most of these mutations. In 2014, we started the revision of the WHO classification and met in Chicago. The revision was published in 2016. And within myeloproliferative neoplasm, we included chronic myeloid leukemia, chronic neutrophilic leukemia, and Philadelphia negative myeloproliferative neoplasms. I wrote the introduction to the review paper in Blood, and in my introduction, I underlined that somatic mutations were mainly used as a diagnostic criterion, typically JAK2 mutation in Polycythemia vera. But in perspective, the idea was to use somatic mutations as prognostic factors or predictive factors or disease-defining lesion. At that time, the best disease-defining lesion was deletion 5q in myelodysplastic syndromes. So let's start first from our patient population at the University of Pavia. We have characterized 2,064 patients collected over years, and no, what okay. In this characterization of driver mutations, we found that PV patients had essentially only JAK2 mutations, the unique mutation in 96% of patients, and exon 12 mutations in 4%. By contrast, ET patients, pre-fibrotic myelofibrosis patients and overt myelofibrosis patients had driver mutations in JAK2 or CALR, MPL, or a few patients were triple negative. I will show that these somatic mutations define distinct nosologic entities, mainly in ET and PMF. Polycythemia vera is characterized, as you well know, from erythrocytosis, frequently combined with leukocytosis and thrombocytosis, and is typically associated with suppressed endogenous hypoproduction. The bone marrow is important for diagnosis because it's hypercellular, and Pine myellosis is one of the distinctive features of the disease. As I told before, we have only JAK2 mutations in these patients. Since 2005, we haven't seen any single patient with polycythemia vera not carrying a somatic mutation in JAK2. In our experience, the 15-year cumulative incidence of thrombosis is about 35%, myelofibrotic transformation about 14%, and leukemic transformation again about 14%. But since we have two types of somatic mutations, JAK2 V617F and exon 12 mutations, is there any difference between these patients? We did a European collaborative study. We found that the typical phenotype of patients with JAK2 exon 12 mutations is isolated erythrocytosis that sometimes is misdiagnosed as idiopathic erythrocytosis. But in terms of incidence of thrombosis, myelofibrotic transformation, leukemic evolution, and overall survival, there is no difference between the unique mutation and the exon 12 mutations. However, polycythemia vera is characterized by a considerable variability in mutant allele frequency or mutant allele burden or variant allele frequency. And the mutant allele burden is lower in patients with essential thrombocythemia than in patients with polycythemia vera. By definition, a mutant allele burden greater than 50% implies that patients have at least a subpopulation of cells that are homozygous for the mutation. And indeed, the way Robert Kralovic, Radek Skoda, and I identified the JAK2 mutation in these patients was the recognition that 9p-ALOH was the most common chromosomal abnormality in patients with myeloproliferative neoplasms, in particular in Polycythemia vera. And the minimal NP-ALOH region included JAK2. What happens typically in patients with Polycythemia vera is that a somatic mutation of JAK2 initially gives rise to an heterozygous clone of cells, but at a certain point, mitotic recombination is responsible for a transition from heterozygosity to homozygosity for the mutation. And at that point, a clone which is homozygous for the mutation expands. In most patients with Polycythemia vera, we have combinations of normal hematopoietic cells, unmutated cells, cells heterozygous for the mutation, and cells homozygous for the mutation. Does the variant allele frequency or mutant allele burden is the mutant allele burden important for the clinical phenotype and clinical outcomes? Again, if you look at chromosomal abnormalities in patients with myeloproliferative neoplasms, uniparental disomy of chromosome 9p, where JAK2 maps, is the most common aberration. And if you consider the variant allele frequency in essential thrombocythemia, Polycythemia vera, post-essential thrombocythemia myelofibrosis, and post-PV myelofibrosis, the variant allele frequency increases regularly, and patients with a post-PV myelofibrosis are essentially fully homozygous for the mutation. The risk of myelofibrotic transformation in patients with Polycythemia vera is about 14% at 15 years, and the JAK2 mutant allele burden is a risk factor for transformation. This observation has been recently confirmed by Jacob Greenfeld, Tony Green group in Cambridge. They studied about 2,000 patients, and they identified two subgroups of patients. One homozygous for the JAK2 mutation, and one heterozygous for the JAK2 mutation. And the first one included mainly patients with PV or myelofibrosis, and they found that there was a significant difference in the risk of myelofibrotic transformation between the two subgroups, with a hazard ratio for myelofibrotic transformation of about 3, comparing JAK2 homozygous with JAK2 heterozygous subgroups. In clinical practice, I would consider a value greater than 50% for mutant allele burden or variant allele frequency as a risk factor for myelofibrotic transformation. Essential thrombocythemia is mainly characterized by thrombocytosis. The bone marrow is normocellular. Sometimes even hypocellular, but there is a proliferation of abnormal megakaryocytes. And here we have a wide spectrum of somatic mutations, including JAK2, CALR, MPL, but a few patients have no of these somatic mutations. Does this count? In my opinion, yes. So let's start with the risk of polycythemic transformation. In the patient population I showed initially, the risk of polycythemic transformation is about 30% at 15 years, but it is only JAK2 mutant patients that proceed to polycythemia vera. In terms of incidence of thrombosis, we found no difference between JAK2 mutant ET and polycythemia vera, which obviously carries the JAK2 mutation. But both these conditions have a much higher risk compared to CALR mutant ET. So essentially, the risk of thrombosis is associated with the JAK2 mutation. What about the risk of myelofibrotic transformation? CALR mutant ET has a high risk of myelofibrotic transformation, which is not different from that of polycythemia vera. And the risk of myelofibrotic transformation of CALR mutant ET is much higher than that of a JAK2 mutant ET. As you know, CALR mutations were identified in 2013, and in the next few years, several groups, including Robert Kralovic in Vienna, William Vanchanquet in Paris, and Stefan Constantinescu in Brussels, defined the mechanism of proliferation. So the mutant carreticulin binds the MPL within the Golgi apparatus, binds irreversibly. It's exported on the surface of the cell bound to the receptor, and then stimulates hematopoietic stem cells with clonal proliferation and megakaryocytes with excessive production of platelets and fibrin deposition. As you know, there are two main types of CALR mutation. One is a 52 base pair deletion, which is much more common in myelofibrosis than in essential thrombocythemia. And the second one is a 5 base pair insertion, very uncommon in myelofibrosis. William Vanchanquet used animal models to show that both mutations induce thrombocytosis in mice, but it is only the 52 deletion that causes myelofibrosis. So we looked for differences in clinical outcomes between patients carrying the CALR type 1 mutation, or 52 base pair deletion, and the CALR type 2 mutation. And the difference is very significant. At 20 years, 60% of patients with type 2 mutation progress to myelofibrosis from essential thrombocythemia, while only 10% of patients with CALR type 2 mutant TT progress to myelofibrosis. And the number of patients at risk is very low after 30 years, so the difference is really very important. Finally, what about MPL mutant TT? Again, we found a wide range of variant allele frequency in these patients because 1P LOH, MPL maps on 1P, is responsible for transition from heterozygosity to homozygosity for the mutation, and from ET to essential ET to primary myelofibrosis. So we have different patterns of clonal evolution and phenotypic switch in different myeloproliferative neoplasms. In JAK2 mutant MPN, it's mainly 9P LOH, which causes transition from ET to polycythemia vera and myelofibrosis. A similar mechanism operates in MPL mutant MPNs, while in CALR-mutant MPNs, the clone remains heterozygous but continuously stimulates megakaryocytes to induce bone marrow fibrosis. From a clinical point of view, we shouldn't use the somatic mutation just for diagnosis, so as a marker of clonality, but we should distinguish between JAK2 mutant TT, CALR mutant TT, MPL mutant ET, and triple negative ET. So JAK2 mutant ET is mainly a condition at a high risk of thrombosis and the progression to polycythemia vera, while CALR mutant ET is mainly a condition at a high risk of myelofibrotic transformation, especially in patients with a type 1-like mutation. MPL mutant ET is also a condition at risk of myelofibrotic transformation, while triple negative ET is a benign disorder with low risk of thrombosis and of myelofibrotic transformation. Probably some of these triple negative patients don't have a myeloproliferative disease, and some of them have an hereditary disorder, like this patient in this family. They carry a atypical germline mutation of JAK2, and so have a hereditary thrombocytosis. Not all familial cases of MPN are hereditary. For instance, in this family, we have 3 patients with JAK2 mutant ET, but the JAK2 mutation was acquired in all patients. In this Australian family, we studied in collaboration with Robert Kralovich. We have a patient with JAK2 mutant primary myelofibrosis, a second one with MPL mutant essential thrombocythemia, and the third one with CALR mutant primary myelofibrosis. What's the mechanism for the acquisition of somatic mutations in multiple members of the same family? So far, common polymorphism predisposing to MPN include JAK2 TERT and more rarely germline mutation that favor the acquisition of somatic driver mutations and development of MPNs. And as I said before, there are a few MPN-like hereditary disorders that are associated with germline mutations in JAK2 or MPL. A common differential diagnosis problem in patients with polycythemia vera is the distinction between, in patients with essential thrombocythemia, is the distinction between essential thrombocythemia and prefibrotic myelofibrosis. These conditions have very similar somatic mutations. It is JAK2, CALR, MPL, or atypical MPL mutations. Prefibrotic myelofibrosis was essentially defined by pathologists, in particular Jürgen Thiele, and is characterized by hypercellularity, while essential thrombocythemia has normocellularity, and proliferation of immature granulocytes as well as of megakaryocytes. In addition, these patients may be anemic, have leukocytosis, palpable splenomegaly, or high LDH level. Although diagnosis of prefibrotic myelofibrosis is demanding, a proper diagnosis is relevant, as you can see in this slide, showing the overall survival of patients with essential thrombocythemia compared with the overall survival of patients with prefibrotic myelofibrosis. So we still don't know what's the difference at molecular level between the two conditions, but in terms of overall survival, distinguishing between the two conditions is really important. Overt primary myelofibrosis is mainly characterized by fibrosis grade 2 or grade 3, and then additional clinical manifestations. We did a collaborative study in Italy. Again, these patients can carry different types of somatic mutations. And so the aim of the study was to understand whether the driver mutation was important from a clinical point of view. And the study, conducted in collaboration with Alessandro Vannucchi in Florence, showed that patients with a CALR mutation have a median survival of about 18 years, while patients with the JAK2 mutation on MPL mutation have a median survival of about 9 years. More importantly, patients which are triple negative, so they don't carry any of these mutations, have a median survival of only 3 years. And these patients are very similar to patients with MDS and bone marrow fibrosis that we described in the JCO a few years ago. Let's now consider how our knowledge of this disorder evolved during time. So before 2005, we didn't know anything about somatic mutations. The median survival of the whole population of patients with primary myelofibrosis was between 10 and 15 years. When JAK2 and MPL mutations were identified, we saw a small difference in overall survival between the two subgroups, but it was only the identification of the CALR mutation that split this subgroup into CALR mutant primary myelofibrosis and triple negative, and so the difference between the different entities became evident. But in addition to driver mutations, we can have additional mutations in myeloid genes, the same genes which are mutated, for instance, in MDS. And to illustrate the complexity of this condition, I will just show a single clinical case. A patient diagnosed with primary myelofibrosis at the age of 68. We are currently characterizing using NGS the whole population I showed before, and we do this using a panel of genes. So this patient had somatic mutations in ZRSR2, a spliceosome gene, JAK2 and IDH1 methylation genes, and JAK2. But if you consider the variant allele frequency, ZRSR2 maps on the X chromosome, all mutant cells essentially carry the somatic mutations in these genes. So there is a fully dominant population of cells carrying these mutations. But it is only a subpopulation, about 50%, which carries previous mutations and also the JAK2 mutation. We don't know the exact order of mutations. We can only say that TET2 or ZRSR2 or IDH1 came first, and then the JAK2 mutation was acquired. But the purpose of this slide is to show that myeloproliferative neoplasms are complex disorders in which the driver mutations play a role, but additional roles are played by somatic mutations in additional genes. And this concept has been developed by William Van Schanke. This illustration indicates that the combination of mutations, so mutations in signaling pathways or spliceosome or epigenetic pathways, the combination of mutation determines the clinical phenotypes, which may be mainly proliferative or mainly myelodysplastic. And as I said, we are currently characterizing the additional mutations in patients with myeloproliferative neoplasms. For instance, we showed that about 60% of patients with primary myelofibrosis have somatic mutations in genes other than JAK2, CALR, or MPL, and that the incidence of somatic mutations in these genes are much higher in overt primary myelofibrosis than in prefibrotic primary myelofibrosis. And we have also tried to use these additional mutations for developing a prognostic model based on clinical features and molecular features. We called this prognostic model MYS70 because it's mainly useful for patients under the age of 70 for deciding allogeneic stem cell transplantation. And by combining clinical features with molecular data, you can stratify patients into 3 risk groups. Clearly, patients belonging to the low-risk group are not candidates to allogeneic stem cell transplantation, while patients belonging to the high-risk group are definitely candidates, and in the intermediate risk group, we can decide on an individual basis. I will stop here, thanking all patients who donate their biological samples, time, participation in clinical trials to us for developing, for understanding the disease, and the Italian Association for Cancer Research, Associazione Italiana per la Ricerca sul Cancro, that is funding our studies on myeloproliferative neoplasms. Thank you very much.
So, Samaria, I'll ask a question first. One of the unique presentations of particularly vera and myelofibrosis or JAK2 mutations in general is clotting in the abdomen. So Budd-Chiari syndrome or some clotting you wouldn't expect. And I'm wondering if there's a specific secondary mutation that distinguishes that kind of clotting from other clotting, and whether you know anything about the pathogenesis of why the abdomen should be why such an atypical site should be a place for clotting.
So are you suggesting, I mean, if you have facing a patient with the Budd-Chiari syndrome?
Yeah. So in that setting, we always look for JAK2 mutations because it's reasonably frequent, and often there's a clue as well, basophils or high hematocrit or something. But the presentation, or even the progression, to have it's a sort of a broader question. Why does abdominal clotting occur in the setting of a JAK2 mutation, which is an atypical site of clotting? And, yeah. Is there something that distinguishes either genetically or clinically those patients from others that have just the standard that have a JAK2 V6 and 7 mutation? Are there other somatic mutations they have, or anything else in your clinical human that you've found that have separated the patients that have clotting at such an unusual site from those that have just DVTs in the setting of their myeloproliferative neoplasm?
The incidence of JAK2 or even MPL or CALR mutations is really high in patients with Budd-Chiari syndrome or atypical thrombosis. Not all patients have a myeloproliferative disorder, but I think that nowadays it's justified to look for somatic mutations in these genes when you see a patient with an atypical thrombosis, because the clinical course of the disease may be influenced by the somatic mutation, and the treatment of these patients may also be influenced by the identification of the JAK2 mutation.
Yes, patients with autoimmune disease sometimes get treated with drugs such as azathioprine and cyclophosphamide and may develop the complications of myelodysplastic syndrome and so on. Are there markers for those patients who might be at higher risk for that development, or who develop markers along the way that might lead one to stop those drugs earlier?
So you mean the risk of myelodysplastic syndromes in patients treated with a cyclophosphamide for autoimmune diseases?
Yes, drugs like azathioprine and cyclophosphamide.
The only relationship I can see is that abnormal, or let's say mutant clones, mutant hematopoietic stem cell clones, are more likely to develop in patients with inflammation, although we don't know exactly the disease. But for instance, in age-related clonal hematopoiesis, which is typical in the elderly, one factor favoring the development of abnormal clones is inflammation. So patients with an inflammatory disease may have mutant clones and may be more likely to develop a myelodysplastic syndrome using a drug like cyclophosphamide. But I mean, there is not much evidence about this. Is my view of the field related to your question. I believe that in clinical practice in the future we are going to use a panel of genes for identifying somatic mutations. For instance, not only in the patients you mentioned, but also in patients undergoing autologous transplantation, because if these patients have age-related clonal hematopoiesis before transplantation, transplantation may result in the development of the myelodysplastic syndrome just because the mutant cells were present before the transplantation. So that's my opinion.
Thank you for a lovely presentation. In your large database, is there any evidence that hydroxyurea will affect the evolution of one of these myeloproliferative disorders to either leukemia or myelofibrosis? This is a common clinical question that patients ask me.
It's a common clinical question, and it's also, let's say, a reason that drug companies use for suggesting the use of alternative treatments. Hydroxyurea is very easy to use, is very useful, involves very few adverse effects. So far, the available studies, including population studies of the Swedish registry, have shown that hydroxyurea does not involve any additional risk of progression from chronic myeloproliferative neoplasm to acute leukemia. Transition to acute leukemia is part of the natural history of the disease, particularly in patients with primary myelofibrosis, but also in patients with polycythemia vera. It's very uncommon in patients with essential thrombocythemia. And from my point of view, the risk is mainly related to the acquisition of additional somatic mutations in myeloid genes, as I showed before. So mainly EZH2, SRSF2, AXL1, and I would say, IDH 1 and 2. That's why, again, in the future, for monitoring the clinical course of the disease, the use of a panel of genes may be useful for predicting transition from chronic phase to accelerated phase or acute myeloid leukemia.
Great. Let's give Dr. Cazzola one more round of applause.